Welcome and thank you for attending today's FASD learning session. I just want to take a moment to introduce myself, and I'm Shelley Burchard. I'm with Alberta Health and I co-chair the FASD Cross Ministry Committee with my co-chair Denise Milne, who's from Human Services. Today's session is the first of the 2013-2014 session, and we are excited to be with you again this year. Our theme for this year is prevention, and we have a promising lineup ahead. We begin with today's presentation by Nancy Poole, who will challenge us to think about what we know about prevention and whether we're actually doing it. And Nancy is all primed from two very exciting conferences that we've just ended yesterday. The first on the Legal Consensus Conference, as well as just yesterday, the International Conference on the FASD, Prevention of FASD ended. There are going to be two wonderful documents coming from those two great meetings. The first is going to be a consensus statement document that will then further the development and movement and growth of the FASD field for us, not only here in Alberta, but beyond. And then also too, from the prevention conference, we were able to pull together a proposal for an international charter. And that will be further determined what the steps are as far as the IHE. But the Institute of Health Economics, I really welcome you to be looking for those documents as they come out. Before I introduce our presenter, there are a few housekeeping tips. You can ask questions during the presentation by using the question and answer module on the right side of your screen. A session facilitator is monitoring the questions and will pose them at suitable times during the presentation. If we aren't able to answer all the questions during the live presentation, we will answer them via email after the session is over. So it is very important for you to include your email address when you ask a question, otherwise we will have no way to send you an answer. The presenter's contact information can be found at the back of your handouts and on the final slide of the presentation. In order to receive your certificate of attendance, you must have signed in after 8:50 a.m. Evaluations for this session will be emailed to you after the session. Please fill them out and return them. We rely on your feedback to continually improve what we do and how we do it. Today's presentation and handouts will be posted for viewing and downloading on the CMC website, which is www.fasd-cmc.alberta.ca. If you experience any technical issues, please email Clayton at clayton.knoll@teacherstv.ca, and I'll spell that out, clayton.knoll@teacher, all small letters, stv.ca. Also, please let your local tech support know, as the problem may originate from your end. As Alberta advances with the FASD 10-year strategic plan, education and training continues to play a key role, and that was definitely a theme in both of the conferences that I mentioned earlier. This is our 5th year of offering sessions and our 2nd year of delivering the materials as webinars. As always, all sessions are taped and made available on the CMC website, as I mentioned earlier. We are pleased with the ongoing interest and attendance in this initiative. We have over, I think it's almost close to 200 people on the webinar today. We appreciate the work of CASA, Child and Families Mental Health, and the Alberta Centre for Child, Family and Community Research in making this initiative a success. Now I have the pleasure of introducing Nancy Poole. Nancy is the Director of Research and Knowledge Translation for the BC Centre for Excellence for Women's Health. She is also the Provincial Research Consultant on Women and Substance Use Issues for BC Women's Hospital and the lead for the Network Action Team on FASD Prevention for the Canada FASD Research Network. Nancy is well known for her collaborative research in FASD prevention, as well as her contributions to training and policy initiatives with local, national, and international governments and organizations. She has edited 2 books, Becoming Trauma Informed in 2012, and Highs and Lows, Canadian Perspectives on Women and Substance Use in 2007, both published by the Centre for Addiction and Mental Health in Ontario. Please join me in welcoming Nancy Poole. Welcome.
Good morning, everyone. It's a great pleasure to be here. As you mentioned, we've had some fabulous FASD conferences, including one on the issue of FAS prevention in the last couple of days. So it's exciting to have one more chance to talk about it while we're all fresh with these ideas. So I'm going to start with a couple of slides that talk a little bit about how our understanding of FASD prevention has changed over time. We started by thinking, if we just focused on alcohol plus pregnancy, we would understand, how to prevent the risk of a child being born with FASD. But over time, we've started to understand these things in the box as really influences on women's drinking and on women's access to services. And it's really changed our thinking about, so what do we need to do to prevent FASD if there's way more at the table than just alcohol plus pregnancy? In fact, when I did a scan of the literature recently, I found all studies that mentioned all of these factors on this slide as connected to women's drinking during pregnancy. I'm not going to go through them all, but I think it's really, important for us to understand so many other intersecting factors that influence women's drinking and which behoove us to think differently about what prevention efforts are needed. The other thing we've done is really started to think a lot more about not only focusing the work of FAS prevention on pregnant women, but also to think about all these other people in this box here who have a role in supporting change. So there's partners and parents and service providers and policymakers and researchers, citizens, communities, etc. And I think it's really important for us to shift our focus from making women solely responsible for this change and really widen the group of us who are thinking about how we prevent FAS. So this, I know, is a complicated slide, but I left it complicated purposely because I think it helps us really understand how many things are in play. This morning, I'm going to talk about each of these 4 levels of prevention in these circles, and also a little bit about supportive alcohol policy that's in the center. And I feel that this is what we've really come to understand over the last decade in our work on FAS prevention, is that we need work at all 4 of these levels. And all 4 of these levels need to mutually reinforce each other. Like if you put all your eggs in level 1 basket and don't put anything in level 2, 3, and 4, you're not going to be successful. And so we need for each community and each province and each country to think about the balance among these levels. How do we support that all of these levels so that we have a comprehensive and supportive net of services and interventions that really help us get to these multiple factors that are in play. Now, around the edge, I've got a few principles that we've also been thinking a lot about. And I just wanted to say that I think, as the work gets more complex, it's really helpful for us to work from this idea of principles for change. And you'll see that I've just mentioned 4 of them. We have many more in other documents that we've published that are on the website of the Canada FASD Research Network. But I just wanted to mention these 4 around the edge, that we need to work from these principles that are women and child-centered. In other words, we're encouraging the agency of women, not powering over, but supporting their efforts to change, that we're thinking about reducing inequities as we're doing it. We're thinking about who's more at risk and how do inequities play out. We're thinking about how we can help women with change orientation, rather than, expecting that the moment you're pregnant, you're immediately every woman's going to be able to immediately stop drinking. It's to really think about what are the steps to change and what are the multiple ways that we can support change with her, not only focused on substances. And finally, I've just done a lot of work over the past 2 years on trauma-informed work about how important it is when we know that a lot of women who have difficulty stopping alcohol use in pregnancy have histories of violence and trauma. And if we know this, then our prevention strategies really need to have an element of being trauma-informed, of helping women to heal. So that's what I'm going to cover this morning, all in one slide, and now I'm going to break it out into more manageable pieces here. As I go through each of these 4 levels, I'm going to be asking you these questions at the end of each one. What are you already doing in this level of prevention? What's working well? And do you have any ideas for how to bring in more of this level of work? So those are the questions. Be warned, and you also can type in other more specific questions as we go along. So let's start with level 1, which is really all about work to raise awareness of the issues related to alcohol and pregnancy. And I'm going to talk about 2 things that are in the research that are evidence-based in terms of efforts that we might take forth. The first one is broad awareness building and health promotion efforts. And we do that through, health education materials like posters and pamphlets. We do that through whole awareness campaigns. We do it through having low-risk drinking guidelines that we discuss with women, all women, not only pregnant women. We also do it through, helping group facilitators have discussions of alcohol. And we can also do it through warning labels. So awareness campaigns in particular have a big potential to influence our awareness of FAS, to encourage information seeking, help women connect to websites or service providers, indicate what services are available and how to access them. And maybe they influence behavior, but more they've been shown to affect awareness. There are so many great examples of work that has been done in Alberta and beyond that we have. I wanted to mention a few examples of campaigns that I think really touch in on the evidence base that we have. And this one is an example from British Columbia, from an Aboriginal network in British Columbia. And you'll notice that it includes both young men and young women, and it links this not drinking during pregnancy to broader community health, healthy pregnancy, healthy baby, healthy nation, etc. And I think that this is the kind of example of work that really reaches these pieces that are important. It raises awareness, it encourages information seeking, and helps people feel empowered to be able to make the change, and extends the change beyond the individual woman to bringing it to whole communities and others. So that's what the literature says. If we can balance a sense of risk and the sense that you can do something about it and that there are people there to support you in that. Here's some other messaging examples that I thought was kind of interesting to mention. Because of the high rate of drinking amongst girls that we've been noticing over the past few years. And here's a couple of examples of tools that have been created that may, guide us in our discussions of alcohol and pregnancy with girls. The picture of the girl with the parts of her body that are affected by alcohol is on the right-hand side here, is from Girl Talk website, and you can see the connection there. But one of the things that they're interested in doing is having parents, teachers, and others have discussions about the risks related to alcohol use, often risks that girls and women don't know that much about. And I think it's kind of an interesting thing to be thinking about the increased risk of breast cancer with heavy drinking, etc. And not only focusing our efforts on teaching about pregnancy and alcohol, but actually widening the story to be thinking about other related risks that might appeal to a girl in her change. On the other side is something I did this year with the Girls Action Foundation that's on their website as well. And it's a piece that empowers girls group facilitators to have discussions about alcohol and other issues like depression and stress and pressure, media pressures, and all other factors that are bearing on girls' decision to use alcohol. And, we tried to give, to support the girls group facilitators to be able to have these discussions with girls. And for that reason, I think, it's really a worthwhile piece as well that gives them lots of ideas about how to do it in a way that encourages girls' agency and thinking through, and getting a critical perspective on the advertising and other pressures that are on them as they're thinking about using. So, lots to say about alcohol awareness work, and I'm sure you'll have lots of examples as well about efforts to raise awareness. Now, the second part of this level 1 I'm mentioning here is something I'm mentioning just because a lot of people think that things like warning labels are really important things to do as a part of pregnancy, alcohol, and pregnancy. And a number of jurisdictions have regulations regarding warning labels related to drinking during pregnancy. But I just wanted to, kind of dampen the total enthusiasm about that in some ways, because alcohol warning labels do at times influence consumer behavior, but the effect is strongest when it's easiest for people to change behavior. And so, you can see in these studies in the bottom about pregnant women specifically that the alcohol warning labels, after they were introduced in the U.S., when they studied pregnant women specifically and the impact on pregnant women, they found that the ones who were already light drinkers were much more influenced by the warning messages, but there wasn't a significant effect for the heavier drinking women. And, and over time, that modest impact on drinking seemed to wear off a bit as women became habituated to the warning labels. So I think, while this is an important thing for us to have as a piece of our basket of tools, it's not one that we want to put all our eggs into, so to speak, and, has a very mild effect, but is one of the many things we could do around raising awareness. So I'm going to stop there and invite some comments or questions, either questions you have specifically or answers to these questions as well. Are you seeing any questions typed in? Okay. Well, let's carry on, and maybe as we go along, the questions will accumulate. Okay. Let's talk about level 2 FASD prevention. What does it include? I'm including here screening and brief intervention, dual-focused interventions, and preconception interventions. So I'm really going to highlight those 3 things as incredibly important to our work. So we have the broad awareness campaigns that reach everybody in society, engage us all in understanding that there's something important here. This level is aimed at all women of childbearing years and their partners and support networks. So you don't have to be pregnant to be having this level of intervention. In fact, I think it's something that we need to do before women are pregnant, if at all possible, is really, talk about alcohol with our healthcare and social service providers and get brief support as needed and get referrals to more intensive support if that's needed as well. It seems to me it's so critical that we get better at having these conversations. And I know in Alberta, that's kind of the focus of some of your prevention work right now. It's actually called the prevention conversation. I think it's incredibly important that we get better at doing this discussion of alcohol and risks of alcohol, including risks in pregnancy, with every woman and their partner and support networks. So, I think this is one of the places in our healthcare and social service systems that a huge shift could happen towards more effective work, where we have some great guidelines from the SOGC. You can see the picture of them there. You can go to the SOGC website and get those, but in general, this has really strong evidence behind it, that these discussions happen. With all healthcare professionals and social service professionals as well. As a society, I don't feel like we're comfortable enough now to be asking this in lots of ways, and there's so much improvement we could be bringing into these conversations. There's a ton of evidence in this area, and as a researcher, I'm always trying to say, let's work with the evidence, and so I'm not going to go into all these in great detail, but just to say, we have evidence for having discussions with women about drink size, about understanding what a standard drink is, and about understanding low-risk drinking guidelines, so alcohol literacy overall. We've got evidence for doing routine screening rather than just screening those women who somehow you think look like the ones who are going to be drinking in pregnancy. They're screening for multiple drugs, not only alcohol, but linking up our work on alcohol and tobacco. There's evidence for that. There's evidence for using these various tools, the CAGE, the audit, the TAs, the tweak, and the timeline follow-back tools. So we have lots of standardized tools that are available. We even have evidence for web and computer-based screening and telephone screening. And we have evidence about the importance of medical school training and continuing education on this, so that healthcare providers are really in a good position to be doing this work. So, it's not like there's not evidence. It's the translation from the evidence into practice that we need. I just want to mention that even though we have this body of evidence, we have way more evidence flowing in every year. And I just picked a couple of things from 2011 on here of recent research examples. One of them is from Australia by Jan Payne and Catherine France and others around, how important it is for health professionals' knowledge, attitudes, and practice to be improved. And they found when they helped increase health professionals' knowledge, that it really meant that way more women had discussions with their providers and were able to access the care that they needed. There's lots of evidence for questionnaire-based counseling, indirect screening, web-based interventions, and new screening tools, such as this substance use risk profile tool that has 3 questions in it. So, we continue to build a really strong evidence base for this level of FAS prevention, having conversations with healthcare and other providers. At the same time, there's also a big body of research on the challenges related to achieving this. There are barriers for the providers. There's a whole bunch of resources needed for them to be able to, not only financial resources like billing codes, but also resources that help them make those referrals successfully into the community agencies. Tools like that help them have handy things that improve alcohol literacy, like standard drink size, pictures, etc., to help educate people about what is a standard drink and how much, is low risk when you're not pregnant, as well as understanding what's best when you are pregnant. And, one of the biggest challenges we have in this area is women's fears that if they tell us that they have an alcohol problem or are using alcohol, that they're automatically going to lose custody of their children. And that, I think it's something that we have so much work to do in terms of creating safety for women to tell. And here's a case of a study by Roberts here, where women avoided and emotionally disengaged from prenatal care because they were afraid that if they were screened in for using alcohol and drugs in the prenatal visits, that they were going to lose custody of their children, and they were also going to be judged by providers. And I think this is a huge area of work for us, is to have these prevention conversations in ways that really support women's change and respect the challenges and burdens that are facing them. So lots of work for us to do in this area. Now, we've got some great ideas in screening and brief intervention from some American research on project choices and project balance. And these are models that actually encourage healthcare providers to have more than one topic of discussion going on at a time with women. And this is a preconception intervention that is about both reducing your alcohol use and using more effective contraception and giving women the choice. Well, if you don't feel that you can do both, can you do one or the other? And really finding that when you are given choice and when, the conversation is a bit wider than alcohol alone, that some absolute risk reduction really does come forth from that. So, they did these studies with a whole bunch of different women in different contexts, and are really refining and adding to this research all the time. But I encourage you to go to the CDC site and see, what they've come up with so far, and really think about this as a possible for improving our prevention conversations. Lots of other people have been doing recent research again on this. This first one example by Morrison Beatty is about sexual risk reduction discussions with adolescent girls, requiring small group plus booster sessions, but really coming up with a great outcome in terms of risk reduction for pregnancy, for reducing the number of partners. Pardon me? There's a question. Oh, okay. For increasing their effect, use of contraception, etc. So I feel like, we've got lots of great research flowing in about these particular issues as well, around having discussions that are brief but effective on more than one issue at once. So let's stop for that question.
So Deb has asked, what about the schools including FASD information in their health classes? I have never seen FASD prevention and the effects of FASD being taught. What are your thoughts on that?
Yes. We don't have a lot of evidence about specifically talking about alcohol and pregnancy in schools, but we do have evidence for talking about alcohol and other substances, right? And finding ways to include that in the curriculum so that those kinds of discussions between teachers and students and, are really beginning to happen, and learning, much more as I did up higher around, what are the risks around alcohol use in general. The challenge about talking specifically about pregnancy and alcohol in schools is that a lot of girls at that point are not really ready to hear, right? The I'm never going to be pregnant. That's not going to happen to me kind of thing. And so we, it seems like that's a bit harder to talk specifically and only about FAS prevention in schools, but there's evidence for talking much more widely about alcohol and tobacco and other substances and risks and pressures and sex and all the other things, and putting that together in a way that doesn't just narrow it into being a conversation about alcohol and pregnancy only, but keeps the conversation wider so that girls can connect to it a little bit better, and boys. This is something that really needs to happen. With boys as well. When I was in Newfoundland a couple of weeks ago at an FAS conference, there was a great example of a community-based agency who was teaching about sexual risk reduction and alcohol and pregnancy, and they had some great T-shirts and whatever, and they were really engaging young people in those discussions about sex, alcohol, risk, etc. And I think that can be a great way to go, is not so much only in the school, but in these community organizations where we can have broader discussions that are not limited by a school curriculum in some ways. I feel so keenly for teachers. They have so much they have to fit in the curriculum already. And if we can enhance this by having community awareness work on these multiple issues, I think it can be really, really helpful. One of the other things, as well as thinking about risk, talking about alcohol and risk in schools, is also, I think, increasing awareness of the disability itself. And that's one of the things that I think is a challenging piece to do, is to create respect for people with disabilities, particularly with disabilities like FAS. And I think that's another whole area of work we have much to be thinking about. And I don't know of any research on that specifically at this point, but I think it would be really interesting for us to be thinking about how to achieve that as well. So, are we doing it? This discussion of alcohol use and related risks with all women of childbearing years and their support networks. Well, in some ways we are. The one picture here is of the screening and brief intervention and referral work by the family physicians. It's a website showing that they're really trying to help physicians get better at alcohol screening, brief intervention, and referral. And there is an algorithm on that site about if the woman's pregnant, about how that discussion changes. There are the SOGC guidelines. There's a great project in Winnipeg where they've taken the Project Choices research and actually built a program for young women on that dual-focused intervention I talked about. And there is training for healthcare professionals on this site, the MDCME site, on FAS prevention, intervention, and diagnosis. So I feel like we're beginning to have the tools in place for physicians on this area. But what we don't have is really a lot of focus on preconception yet. And this was mentioned a number of times in this conference this week on FAS prevention. And I think, we have recent research examples about how important it is to have these discussions before women are pregnant, and how important it is specifically for us to be having discussions about the risks of binge drinking before we're pregnant. And we know that a lot of women don't actually plan their pregnancies. So, there's such risk that happens if you are getting pregnant, aren't aware of it for some time. And the Americans have a national campaign designed to improve the health of women and babies by promoting preconception health and health care. And I think it's something that we in Canada could really be putting a lot more energy into. So I'll stop again here and just see if you have any comments about what you're already doing around screening, brief intervention, preconception interventions, etc. This is an area we're doing a lot of work on in BC, as well as I know work is progressing in Alberta as well on the prevention conversation of really empowering all of us to do these conversations in an evidence-based way. And you'll notice a number of times I've got the word motivational interviewing within all of these different effective approaches. And really, I think it is important for us not to just come both barrels at women around, you got to stop kind of thing, but to elicit from them their ideas for change and really make it a conversation as opposed to a lecture. And that's what the motivational interviewing approach really supports, is guidance around taking a more guiding stance for change. And if we go back to the first and think about these as kind of some of the factors that are associated with women's alcohol use and pregnancy, I think it really behooves us to think about how to have those conversations in ways that really helps women tell us what's bearing on their alcohol use. We could even start with questions like, how does alcohol fit in your life, rather than starting with, how many drinks are you drinking a day, kind of a way. And so this is an area that I feel is really ripe for us to do way better in. And hopefully this presentation will cause some thinking about what those options are. So anything from afar? No? All right, let's go on to level 3. Now, many of you may know that I've done a lot of work in this particular area of intervention and support, evaluation of programs, etc. So, I'm very much attached to this level as well as to the previous one in terms of our work and figuring out how to do this piece well, so that when those healthcare providers and other social service providers have the prevention conversation, if women are struggling, that we have wonderful specialized support for pregnant women with alcohol problems that we can help women engage with, and that there's a smooth linkage between level 2 and level 3 in all of the work we do. So, what does this level of work look like? Well, in urban settings across Canada, including here in Edmonton with the HER program, we have lots of these kind of one-stop drop-in services that have really low thresholds. It's really about helping women engage, whatever issue they want to begin with. And often it really helps if these services are drop-in and outreach oriented and really create a space for, where we so want to support you, rather than women feeling like I'm going to be judged if I go there, and I'm going to have to do this, and they're going to send me to treatment even though I don't want to go to treatment at this point, and blah, blah, blah. And I feel like, this is really critical, that we figure out how to wrap care around the mother-child unit here, and really think about nutrition and all those other trauma, all those other issues that often make it difficult for women to see their way through to being healthy in pregnancy. And sort of create a little bit of wind beneath her wings, so to speak. Really see this as a place to empower her to be able to make choices that are really the very best that she can do for herself and her children. In many communities that I've been in smaller settings, even though they don't have a one-stop program like a She Way or a Her Way Home or the Her program here, or many of the other places throughout the province in Cold Lake, everywhere. In the smaller settings, often it's delivered through a network of community-based services, and that's even more challenging in some ways than having the one-stop shop, because it means we have to connect up a lot of people in different local community services and agree to work to create a net of support amongst those services. And I've seen it work so well in many small communities in British Columbia, and I just want to honor, those who are able to build that, what I call a perinatal services network of people all working from these principles that we need to provide holistic support and make the threshold really low in order for women to feel safe to access care. These services often offer health, prenatal services, addiction services, maternity care, housing, advocacy, support to be connected to education, child health services, child welfare services, etc. So they're very complex, specialized services that are needed as a part of this multi-level support for to prevent FAS. This picture of this article on the right-hand side here, this is actually downloadable from the CanFast Research Network site. And I really encourage you to have a look at it. It's the story of 4 of these one-stop drop-in services in communities in Manitoba, British Columbia, and other places as well. And it really, what the service providers do is reflect on how they developed these services and what lessons they've learned as they've gone along. It's quite remarkable, I think. And in the center of it, there's a table that has the sort of 6 main principles that they came up with, that they found when we looked at what they all said they were doing and what they all said was important. There's a table that kind of summarizes these core ideas of what's involved in these services. So I highly recommend this document as a really pragmatic way of seeing what this work involves and what people have learned as they've delivered it. What we found at She Way, and I did an evaluation with She way back now, and continue to follow their remarkable work. And there's some excellent research also from Breaking the Cycle in Toronto, done by Mary Motts and Margaret Leslie and others. And this work shows that early engagement of pregnant women who use substances affects a range of outcomes, both for mothers and children. Women who participate in these programs are more likely to keep custody of their child and have higher rates of accessing addictions treatment. Children who are involved with mothers in these comprehensive programs have been shown to have enhanced developmental outcomes. So, it just speaks to me that we so need to get behind these specialized prenatal programs. One of the things I think that really happens, in these programs is they work better when maternity care is linked to them. And there's this continuity of care between the community and the hospital for women who have used substances in pregnancy. And, I think I'm just showing the example of the First Square Combined Care Unit at BC Women's Hospital because that's where I am. But I really want you to understand there are others across the country, Teacup in Toronto and many other places across the country that have thought through how important it is for us to make maternity care respectful of women who have used substances during pregnancy and to work to help them get the care they so richly deserve, rather than making it difficult for them to get that support. And at BC Women's Hospital, we actually work to support women by helping them stay longer postpartum to be able to see if they are someone that could take their baby home with adequate supports. And so we work really closely with Child Protection to be with us and the mother in those 10 days postpartum to really, do the best we can to get behind that mother-child unit, to support early attachment, to do all these things for which there is evidence, rather than making mothers feel badly about what they've done. Instead, engage them in seeing the impact of their use and to help them be part of the solution with their children. And we've just seen remarkable change from that. And I've quoted Ron Abrams and others' paper here from 2007 about this rooming in process, where we don't immediately take the children away from mothers, but support them to stay together whatever possible, and the tremendously positive outcomes we're seeing from doing that. So I'll stop for a question.
Deb has asked, I have been fostering for 32 years and have adopted several FASD children, so I've had to deal with many medical professionals over the years. You would not believe the attitudes of the professionals. They are judgmental and can be downright rude, until I explain that I am either the adopted mother or the foster parent. Is there specialized training for the average doctor in this particular area?
Really important question. And it really, I think, gives a sense of how critical these kinds of services are, and the change that we need to make with physicians. As I mentioned up in the level 2 area, we are, getting lots of evidence for how important it is to change health professionals' knowledge, attitudes, and practice. And you'll notice I put attitudes as well as knowledge in there, because that's what is shown, is that we do need to help process this with health professionals. And this particular piece here at the bottom, the MDCME site, has the endorsement of 17 medical schools from across Canada who are actually hoping that physicians will come and learn. And it's got 3 sections. Part of it, the first section is I wrote with them, which is about attitudes towards women during pregnancy who are using, and prevention. The middle section is about diagnosis, and the final section is about helping physicians work with families where there is an affected child and really shift their attitudes towards how to help families. And that was written by Jan Lutke, who's another person who works with the CanFast Research Network. I think it's a brilliant piece that's really not been been accessed in the way that it might be. And I really encourage you to get, your local doctors to go and access this online training, which is accredited and which I think would really begin the process of that shift that's so needed. And, I don't know about you, but even in my own family, I find there's a lot of attitudes towards alcohol use in pregnancy and a lot of naivete about how complex it is, a lot of judgment about people continuing to use. And, over time, my mother has said to me things like, well, I don't get it, Nancy, can't they just use birth control? Like, what is the problem? And I think that kind of judgment and lack of understanding of these, multitudinous pressures weighing on women and making it difficult for them to change, like experience of violence and depression, like poor nutrition, like having been in residential school, like not knowing that they're pregnant already, not being aware that it's a problem, having this perception that small amounts of alcohol don't matter, having access to quality prenatal care, being stressed about money, not having social support. There are so many things that may be in play, and for us to be so judgmental of mothers who haven't been able to stop, I think, we really need to look more at ourselves and our systems of care and take that responsibility up as I've got there to really be thinking about, are we doing enough to make our systems of care welcome for women and for people who are mothering children with FAS, as you say. It's such a challenge that we have before us. And I think it's about our ambivalence about alcohol overall in some ways in our society. I find that my healthcare provider doesn't often ask me about, alcohol in general. They're much more likely to ask me about sexual practices. It's interesting then to engage in conversations about substance use. And I think we, as a society, this is one of our major concerns, is to move forth and show more respect for people who have difficulty with alcohol and towards people with the disability and those who are caring for them. So brilliant question, and I think hones right in on the problem before us. So we've got lots of new research on this level of prevention. We've got research from the Indigenous people in the Northern Plains states in the U.S. about how enhanced case management can really be supportive of mothers who are having difficulty during pregnancy, reducing their substance use and improving their health. We've got evidence about the importance of this kind of multidisciplinary work in inner city hospital outpatient clinics in the U.S. We've got evidence from work done by midwives enhancing that continuity of care I talked about and extending support into the postpartum period from Australia's antenatal clinics. And we've got evidence also from Hawaii. This picture on the right-hand side is from a clinic in Hawaii about using a comprehensive harm reduction model, by which they mean providing transportation, childcare, social services, family planning, addiction medicine, etc., and also including support on other drugs such as methamphetamine, not only alcohol and tobacco and whatever. So, it just keeps on rolling in. That level 3 prevention work is important. It's working. We need to do it. So let's stop there before I go to level 4 and just see if you have any comments about work being done on level 3 prevention in Alberta. I was part of a research team in, I'm a former, not an old, couldn't possibly be old, a former Albertan. I worked for ADAC for many years. And I was involved in a research project of an ADAC program called Enhanced Services for Women that was really designed initially, we thought, to help pregnant women get connected to treatment. And what we found as we offered, sort of community-based support to have discussions about substance use and pregnancy, that a lot of the women who came for that support, because ADAC put those enhanced services for women in place, was a lot of the women who came actually didn't want to go to treatment per se. They wanted to do better, and they had a lot of ideas about how to do better, but they found that actually it was more helpful to them to get support in other areas rather than trying to go to treatment when they were actually pregnant. And one of the things that was so interesting about that service was that in the research, we found when we asked the women what was most helpful to them was that they said things like, the counselor listened to me. She was able to hear where I was ready to start. And maybe it was that I needed to get better housing, or maybe it was that I needed to leave the relationship I was in that wasn't supportive, and my partner was a big drinker and I needed to not be there, right? And so instead of forcing me into a path direct to treatment as if that was the only answer for substance use and pregnancy, they were willing to hear that this is what I needed to do. I needed to get a better place to live and get a more supportive network of people around me. And I remember the one woman in the research said, the best thing about the provider was that she had good ears. And I thought that was such a nice way of saying it, that what we need to do in level 3 is so much think about hearing all these ways that we can be supportive in a holistic way and not stay focused narrowly on substance use as the only change we're going for. We so need to begin with the determinants of health that make it possible for women to be able to reduce their substance use. We can't take away the substance use before we've supported a range of other outcomes. And I think, providers are really starting to understand that instead of having the expectation that mothers adapt to systems, that we reorganize ourselves to really get behind what mothers are able to do. So, you can tell I'm not at all passionate about level 3 work. So I'm going to head into the level 4 work as well. And, it's interesting because when I first started to think about FAS prevention, I didn't actually have level 4 in my picture. I had only the first 3. And so this level of prevention is actually about postpartum support, and it sounds kind of, and support for new mothers and children, and it sounds kind of odd that we would consider this FAS prevention because pregnancy is already over, but in fact this is all about prevention of another child being born with FAS, and it's also about prevention of adverse outcomes in children. It's about wrapping that care around the mother and child unit and really ensuring that the kids get connected to supports that they need. And the mothers as well are supported in doing everything they can to create the best possible outcomes for themselves and their children. Now, most of you, I imagine, who are listening this today have heard the words PCAP before, because there's some fabulous programs across Alberta that are working from this model. But basically, it is an evidence-based model that was initially developed at the University of Washington. And the point of it is that we don't just limit our support to the postpartum period, but actually to the new mother and child development period, and really provide long-term one-on-one mentoring program for women at highest risk for giving birth to a baby exposed to prenatal alcohol use, and really address the complex backgrounds of many of the mothers, including their trauma, child abuse, mental illness, violence, poverty, and even having FAS themselves. So the whole aim of it is to help prevent future alcohol and drug exposed births amongst high-risk mothers who've already delivered at least one exposed child. This is a great program, and not only is it, effective, but it's also cost effective. And I think this is really important for us to think about, because so often we think, well, 3 years, one-on-one mentoring, but they've been able to show just how much this has been able to influence reduction in alcohol use and prenatal exposure. And, I think we have to shift our thinking towards what is effective rather than presuming that we already know and that it's awareness only, or it's pregnancy tests in washrooms that's going to make the difference. This kind of, 4-level, multifaceted, long and short-term support is really critical for us to get and to think about how it all fits together. We had some people present at the FASD conference we just came from about the effectiveness of their work in peer mentoring. And I just want to honor the fact that we so often think that somehow all of this work has to be done by professionals, but really there's great evidence beginning to emerge from some of the peer mentoring programs, really showing that moms who've been there are often really excellent supports for moms that are in process. And, the document on the right-hand side there of Moms Mentoring Moms group is from my hometown in Victoria, led by a fantastic mother, Janet Christie. And I just want to say that I don't think that we give enough financial support for the delivery of these programs and the training of moms to be coaches for other moms, nor do we give enough support for evaluations like this one. And I think it's an area of level 4 support that really we could pay way more attention to than we have been, and can really, I think, reinforce the changes of those mothers who have been able to make the changes, really empower them to take that next step towards giving back to others, as we know is so critical often in recovery from addiction, is the chance to give back as well and to share the strength of having moved on. So I think, that's a really important piece for us to consider. The other area of postpartum level 4 support that's got tremendous evidence behind it is the idea of home visiting in the postpartum period. We don't do enough to support mothers to understand what's normal, what's not normal, how do I do this, is this all right? Kind of thing. We just don't have enough about how to parent in those early moments at all. And I think the benefits of home visiting programs have really shined through in terms of helping people change substance use, helping them develop parenting skills, helping them to develop stronger parent-child relationships, helping them be healthy reproductively, etc. So, so much has been done by David Olds and others in the U.S. But he's done a randomized control trial really recently that builds on his earlier work around showing the effectiveness this overall with mothers who are and fathers who are struggling, but is really beginning to show very long-term benefits, and also really cost-effective benefits in terms of reducing the amount of money spent on these other types of programs for needy families in the U.S. when they were having the nurse home visiting access. So, you know, lots of potential for us to do more of this work as part of FAS prevention as well. Really, you know, focusing on parenting in the home and giving lots of supports for getting through those early periods and creating the best possible outcomes for children and parents both. Now, my area of work, as you can tell by saying that I once worked for ADAC, is really around as a substance use treatment researcher. And I want to spend a few minutes talking about the importance of having tailored substance use treatment for pregnant women and new mothers and longer-term mothers. And it's another big area where we've got lots of research showing how effective it is, but we have almost no programs in the addictions field that are oriented towards moms and kids and treatment of more than just substance use concerns, but also trauma and other related concerns facing women. So the first thing I wanted to mention on the left-hand side there is the Women Co-occurring Disorders and Violence study. And now it was an amazing study done in the U.S. Over the past few years that showed that when you integrated support for violence, mental health, and substance use concerns, trauma and violence, mental health, and substance use concerns, that women's outcomes in treatment were greatly improved. And I feel like the addictions field is just beginning to engage with how we can more actively integrate work on trauma into the context of our treatment overall. And this study is a great example of how you can do this, and it doesn't cost more to do it. It means, again, us reorganizing ourselves as service providers rather than expecting that women are going to be able to see how to access our care if we don't make it more accessible and more holistic in the approach. The second area of evidence we have is around collaboration between addictions treatment and child welfare. And I think this is a hugely important area. If we're going to get at that fear that women had, as we saw in that earlier study, around being afraid if they come for help that they're going to lose custody, but instead see how can we wrap care around both mothers and children. And I mean, I'm not suggesting that there will never be apprehensions. I mean, but more that we start from the assumption that we can make it work if we provide supports, rather than starting from the assumption that somehow we always have to remove children. And so this is what we're beginning to see in the addictions field. And on the right-hand side here, the Moms and Kids 2 program offered by the Jean Tweed Center in Toronto, you can see is a program that they worked with Children's Aid Society and continue to deliver with the support of the Toronto Children's Aid Society, which really thinks about what are the needs of moms and kids. Well, one thing we can do is make it less intensive. That a lot of women say, I don't want to go to treatment because it's way too tiring. I can't function with my kids and do a full day of addictions treatment. So they've created it to be 3 days a week and only between 10 and 3, so that, mothers and kids can actually achieve it and not have to drop out because it's too overwhelming. They offer breakfast. They offer play groups. They offer healthy parenting. They offer support on women's health and substance use and relapse prevention. They offer group therapy, and they offer a whole lot of programs for the children themselves. And then the linkage for bringing the moms and kids together. So I think we've really fallen down in this particular area in terms of our work on FAS prevention, because we haven't been able to bring what we know about effective treatment for women to be tailored towards moms and kids, as opposed to a generic treatment thing that mothers are somehow supposed to figure out how to cope with, and instead really tailor treatment for moms and kids. So we have a question?
Nancy, I just have a comment about something that's happening here in Edmonton. It's very exciting. It's about a program that is being offered to women through Addictions and Mental Health. And it's for women who are working with the addictions program in Addictions and Mental Health. They're working with mental health professionals to deliver an evidence-based parenting program called Incredible Years. And the Incredible Years program was developed specifically to help parents in very high-risk situations with children who have mental health and behavioral issues. So this program is being modified to specifically address addictions, and they've had their first go at it, and it's been very well received. They're so excited about it. And it's actually introducing an element into a very well-established, well-researched parenting program that is actually an international program.
Great.
Yeah, so it's a great experiment.
And that's exactly, the kinds of questions that we, the kind of thing that I wanted to hear today about what are we already doing and how can we bring, what's working well and how can we bring that in. And I really am glad you mentioned that you took it and tailored, right? And I think that's a really important thing for us to recognize, that there's no generic program, right, that's going to work everywhere with all different types of women. And so we need to think about what are the core elements that have been what's made it successful, and not lose those, have fidelity to those, and at the same time figure out how to tailor it.
One of the philosophies of the One of the philosophies of the Incredible Years program is that while parents come with many, many personal issues, their drive to be a good parent is paramount. Mm-hmm. And once they begin to experience success as a parent, they have the confidence to address other issues. And that, I believe, is a really good philosophy to take into the addictions field.
Yeah.
Because at that point with young children, that is what women are concerned about. Mm-hmm. And if they can feel successful as a mother, then they'll start to look at this other stuff.
Yeah. We delivered an evidence-based program as well at the Aurora Center in Vancouver within the addictions treatment program that was about parenting. It was based on a model called re-parenting. And it was about the idea that good parenting wasn't only about setting schedules and, doing things that are concrete skills, but it was also about reflecting on how you were parented. And to think about, the strengths of that and the weaknesses of that, and to think about, are you reproducing that? whatever your parenting was in your current relationship with your child, and is that what you want to do? And it's so interesting because I think we so seldom create those parenting reflection moments in our society where we really are, without having to be judged as a parent, we have the chance to have a conversation about, my dad was super strict and I rebelled against that, and so I'm doing a totally laissez-faire thing or whatever, right? And then having the chance to think about, well, what are the implications of going laissez-faire as opposed to super strict? And, so is there a place in the center that actually is a more balanced place so that we're not simply parenting in reaction, or, we have much more chance to think about what do we know about creating structure with kids at different ages, and how does that help them, so that you're not actually coming to the place of thinking, well, if I just let them run wild, they'll be way better off than the strictness that I faced or whatever, right? So I think this kind of thing that you're discussing as being offered here is exactly what we need to be testing and thinking about, and how do we do it in a way that brings in the support of the mental health, substance use, child welfare, all these systems, and we take it together so that we feel like we're working in tandem to get behind parenting, as opposed to making women feel inadequate about their parenting and afraid to come for help because we're going to somehow judge that. So, so critical and so welcome to hear that as something that's being put in place. And we can do it. I mean, programs like Jean Tweed have figured it out. I'm sure there's many others. I'm sure Aventa and Henwood and others are all thinking about these ways of working differently with moms. And that was one of the reasons why we initially developed intensive day treatment programs, was because we wanted to think about, people who didn't want to leave their kids while in treatment. And I think that, the group like Jean Tweed, who've not only delivered day treatment, but they're delivering it even not super intensive, so that moms can actually do it as opposed to having to drop out, Shelley.
There's another question from some Jolene Doig, I believe is how you pronounce her name. She mentions here, I think awareness is huge. One of our young students that had their child diagnosed with FASD said her first reaction was that she thought it only happened with Aboriginal children. It was a very eye-opening experience to us as teachers that perhaps we needed to do more we need to be more educated. And I just want to add to that, as far from the FASD cross-ministry perspective, what we are currently going to be looking at is trying to get in front of the Teachers Convention and be part of the Teachers Convention coming up in the upcoming year, which apparently is a bit of a process, but we're going to take the journey to get there and to be hopefully in front of that group, to be able to bring in the information into the educators, because I agree with that comment very much, and there are myths to dispel, such as she mentioned, so I just wanted to add that part. But Nancy, do you have anything to say?
Yeah, I think that's excellent. Now, this picture where it says girls, women, and alcohol on this particular one, this has been published by the province of Manitoba, but it's built on one that I did a number of years ago. And I did it because I was at an FASD conference, and there was a panel of birth mothers sitting in front of us, and they were all middle class birth mothers. And they said, you know what? You completely missed us. You never talked about alcohol and pregnancy with us. You were always assuming it was some poor woman or some Aboriginal woman or whatever, and your biases and your stigma got in the way of us knowing what we needed to do in pregnancy. And so I think that whole point of trying to broaden the awareness to include and to tailor our awareness to different subgroups of women, so that we don't miss middle-class women and we don't over-scrutinize Aboriginal women. Because in fact, I think that's a real disservice to them. Aboriginal women as a whole actually drink less than women in general in Canada, but yet we have all these, perceptions that somehow there are higher levels of alcohol users. And I think it's really, really a really important point that we move past our stereotypes and start thinking about, well, what might be helpful. And I noticed that at the conference this week, people were talking about some amazing work being done on the Treaty 6 and Treaty 7 nations in Alberta to do broad-based community learning and support. And I feel like, many of the Aboriginal communities are doing much better than the non-Aboriginal communities in terms of building awareness and putting together FASD, quality FASD prevention programming. And so, I think they should be applauded, and we should, get over ourselves on this one and really help build awareness in many different pockets. I think, there's so much we could do in integrating alcohol interventions with tobacco interventions, which are broad-based, et cetera. And, there seems to be so much less stigma around tobacco use in pregnancy in some ways. And if we can, try and build through many, many different avenues where we know we can reach women who may be at risk and who may not be able to hear in the ways that we've raised awareness so far. So lots and lots to do on that level. But just to go back to the Aboriginal women for a second, I wanted to mention that there's been some fabulous work done on what Aboriginal women actually think would be helpful in treatment. And I really encourage you to go and see this fabulous video clip that they created out of this research project that's called From Stilettos to Moccasins, and it's on YouTube. And but what the Aboriginal women in treatment said that they thought would be helpful in terms of support is that service providers show empathy, show non-judgment, provide hope, to show that it's, change can happen, to recognize the impact of trauma, to have two-way communication instead of just, I'm going to tell you what to do, to show care, to link to spirituality, and to assist women moving towards the future, and as well as acknowledging the past. I just thought it's such a brilliant sort of summary of what good practice has been shown to be in motivational interviewing and many other places, and that they were able, from their own experience and voices, give us the message of what they think it could be really helpful in their healing. So, I don't want to overemphasize Aboriginal women's healing, but I also want to honor the fact that they have done some amazing work and are still doing some excellent work in terms of substance use, mothering, and treatment, and have been more likely in the NADAP programs to have family treatment in some ways than we've had in the non-Native perspective. Another area where Aboriginal women have really taken some very amazing steps is in community alcohol policy. And I just want to mention that we often don't include that in our discussions of FAS prevention, but we do have evidence that when communities overall have less high levels of alcohol use, when there are community alcohol policies and lots of other supports in terms of policy and guidelines and legislation, that we can in fact reduce overall alcohol use and reduce risk of FAS. So I don't want to let the alcohol policy folks off the hook for taking up their part of what it might be. And I just wanted to mention that one picture of the tree there is from a group of, it's a video called Yalara from a group of women in the Fitzroy Valley in Australia who were at this conference this week with us here in Edmonton, and who really show that if you build a community alcohol policy, you can reduce FAS as well. It's a beautiful film. They showed it to the United Nations, and it's had such great response around the world, but initiated by two Indigenous women in a small community in Western Australia, and have really shown us all what this can look like. So I'm going to pause there and just see if there's any more questions or thoughts about, this postpartum work, home visiting, mentoring, addictions treatment, and alcohol policy areas. It's, a big chunk to be thinking about. But do people have any other comments they want to make about this level of prevention? Are there any addictions treatment providers on the line, I'm wondering, who want to reflect on the women in treatment part? People from Alberta Health Services who are working on the community level? I'd love to hear what you think about the moms and kids piece and how we can, do in our outpatient and day treatment and residential treatment, really shift that practice, and if they're doing anything. Is there anybody on the line there? Okay, so I'm just going to wrap it up then, to come back to that idea that there are 4 levels of FASD prevention, plus work on alcohol policy. That we are likely to be only working in one of these areas, any one of us. And that's incredibly important for us to understand, that no individual group or agency is responsible for all 4 of these levels. But I think what's most important that we get is that we all have a piece to play, a part to play in the greater whole. And we need to think about how we're linking up and supporting all these different levels of work. So if awareness in schools is your major area, how are you linking to the people who are doing brief intervention? Right? And what do you know in your community about the specialized supports that are available, both for, teenage women, but also for older women? How are we linking support for those who have already had a child affected and who are at risk again for that? And so I really feel that this is our work at this point, is both to understand all these levels, but to figure out, okay, what am I doing? On what level am I working? And how am I connected to the other levels? And how are we as communities and health systems thinking about all these things as a group, and thinking about the balance amongst them, and not getting sidetracked into saying, oh, this is the only way, but to see that it's many roads, one journey, right? And that is the way we need to link up our work together.
I do have a question. What are your thoughts on the interplay between assessment, diagnosis, and prevention? Because I know that there's that's always a bit of a conversation as far as, is it included within prevention model, or is it something that stands alone on outside of?
Oh, I'm so glad you raised that. I meant to say something about that along the way. I've been trying to convince the diagnostic clinics for years that they have a role in the level 4 prevention work, right? That they have a role in having a social worker available that is someone who can investigate where is the birth mother if she's not the one who's bringing the child in. And often, by that point, she isn't the one bringing the child in, right? And seeing if she's all right, seeing if she's connected to services or if she wants to be connected to services. And I know that that's quite controversial because it does mean trying to find her in various ways. But to me, it seems so critical that we not put all our energy into the diagnosis and assessment of the child, but we really work at the same time on prevention. And we think about who is that birth mother? Where is she? How might we support her? Not to, force her into treatment, but to invite her to see that she is so worthy of support and attention, and maybe could even be part of being connected to this child's long-term development as a way of mitigating her loss, her and the need for her to keep having children in order to fill that hole, right? So I feel we have a great responsibility in FAS prevention as diagnostic clinics to be inclusive of level 4 prevention. So brilliant question.
And I would also add that with the 25 FASD assessment diagnostic clinics here in Alberta, that they do very much embrace the a diagnosis for two, and that it is that very, I always call it soft conversation to have, because it is about trying to bring in biomom and into the process as it makes the most sense, and it's often the most healing moments that then can happen of just that acceptance and that relational bond and that kind of thing. So I do know that those attempts are made, and I've heard the stories where it has happened.
Yeah.
I also know the complexity of also getting there. So thank you very much for your
It's
acknowledgement
really,
of assessment diagnosis as sort of that level 4 process.
Yeah, I think it also happens with the level 3 mothers, and the work we've done to connect up the hospital at BC Women's. We used to take the mothers in, put the kids in special care nursery, focus all the attention on the kids, and the mothers just drifted back to the community. And guess what they did? They got pregnant again. And then they came in, and the exact same thing happened. They delivered the baby. We put all the energy towards the baby, and she just fell off into the Netherlands again. And I think, what we really see is such incredible benefit from that moment of centering our care on the mother-child unit. And that doesn't mean that the mother automatically retains custody, but as you say, can be a tremendously healing thing about being part of the story from here, right? And it may just be that she gets to know how her kid's doing. There may be all kinds of levels of ways in which she might be involved, that it doesn't have to be this either you have custody or you don't have custody, but it's, it's a continuum that could be tremendously healing for the mother and the child, and certainly at the moment of delivery is really important for that early skin-to-skin attachment that we know is critically important. So, I just can't say enough about the fact that while it may appear to be that we should only be focusing on the child in those moments, that all the evidence shows otherwise, that if we wrap the care around both in various ways, we can really make a huge difference towards mothers and children, and prevent further cases. Yeah.
I have another question here from Nikki. I am interested in the research aspect of your work, wondering how it is possible to quantify results or outcomes in regards to evaluation of the effectiveness of prevention programming.
Great question. Well, I was hoping by today I could actually refer you to a website about that, but in the next 2 weeks or so, we'll have a website up. I'm not sure whether I included it here or not. No. But we have been really studying that very question about quantifying a whole range of outcomes. And partly we've gone through every evaluation of every program that has been working in this area over the past decade. And we've built an evaluation framework from that. And it does include quantifying a lot of different pieces of the continuum that whether it means quantifying improvements in nutritional status, in housing status, in substance use, a whole range of things. And we are about to launch a website that gives you ideas about how to do that exactly. It's going to be called www.fasdevaluation.ca. Very simple, straightforward website. But that question that you're asking has been incredibly important for us as well, is how do we help programs as they're designing interventions and support of various kinds to actually know how they're doing. So we also have ways of assessing trauma support, whether you're effectively taking a disability lens to your programming. In other words, recognizing if the mother herself has FASD and what adaptations in your programs you need to make. So I think you're going to be really pleased about the fact it's taken us 2 years of sifting through things that have already been used, and also drawing from related fields such as Jean mentioned before, of looking in the parenting field and other fields about how have they analyzed outcomes around parenting and child development, etc. So we've added all these together and mounted them on a website that you can go and find what others have used, what you might use from standardized tools, and hopefully over the next few years we can add to that you can continue to send us more ideas, and we can build a really strong evaluation tool base for us all to draw from, because that's how we get to here. We evidence the good work we're doing, and sometimes it also involves us actually moving higher than individual evaluations and doing multi-site evaluations with control groups, so that we can actually see, from the research level, even beyond the evaluation level, what is working well, for whom, in what context, and that is that's my goal, certainly in the next few years.
And one particular project that was quite exciting out of the Year 5 evaluation of the 10-year FASD 10-year strategic plan here in Alberta was with the Parent-Child Assistance Program.
Yeah.
And it not only brought in the quantitative information, but it also brought in the qualitative experience. And I remember, this is from my own experience, of we had overtasked the networks and for data and collection, and we needed to know what they're doing so we could say those good stories, so we could then further the growth and development of all that's happening across Alberta. And I remember with the mentors of knowing that we were then tasking them again for more information, and knowing that the work that they do is so integral and can be, it's so heart-based, it's so relationship-based, not sure how they would respond to this. And then Dr. Jackie Pye and her team went in. I happened to walk in at the AGM meeting and to see all of the quilt squares and I wasn't sure what I might see, but it was positive and growth and trees and hearts and rainbows and seeing, and even through tears there was hope. Mm-hmm. And to have it where those were the themes that were quickly seen through the work that they have, I think that it's also too important to accompany that qualitative work with the quantitative, because that's one of the most powerful stories that we've been able to really showcase on multi-levels within government for further funding decisions, as well as external, to be able to know that we're doing a good thing.
Yeah. It's so interesting that all of the programs that I know of that have shown good evidence, like the one I was mentioning here from the Women Co-occurring Disorders and Violence Study, included women themselves who had trauma, mental health, and substance use in the design and the evaluation, right? And, I can't, as I was saying about the peer mentoring programs too, we have to hear the people who are in the issue in order to understand what to do. We can't just decide that somehow we as researchers or program providers understand it totally. And I feel that when we work together as researchers, service providers, government planners, and women themselves, when we have those 4 groups thinking through what to do together, we'll really find our way forth in ways that are very effective. And I think that, when I did the evaluation of She-Way, I did a focus group with the women as well as service providers and chart reviews and various other things. But even within the discussion with the women of what they found helpful, I used 2 different methods. I used a focus group for those women who were good at telling me what was they got, and also used an art project, right? And like the quilting one and whatever, where people who can't say it in words or can't conceptualize it in words are able to tell it in other ways. And so they created this great collage of, what was helpful to them. And Dr. Badri from the University of Calgary has also used photo voice with Northern women around telling what's helpful, as opposed to always expecting that they're going to be able to tell us in ways that fit into research questionnaires or focus groups. And the quilting project's another important thing. And so I think, we need to be multi-method. We need to be multi-sectoral in the way we come to our understandings of what works and for whom, in what context. And that's the great stuff of this, is to figure out how to reach and engage and have everybody that's at the bottom of this slide really a part of the work together. It's not the government deciding what's going to work. It's not the service providers. It's not the women only. It's not, communities only. It's all of these together, figuring out a common plan that brings the expertise from policy, practice, experience together, and research. Can't forget the researchers. So, I think we're really at a great moment in time because we have such interest by the Alberta government in this area around FAS prevention, and I feel really hopeful with a tremendous effort that's being put into this work that we will really move forth significantly and see some great changes in the number of children affected and the number of women who get healthy and strong through these various levels of intervention. So yeah, it's a great moment for us to be having this presentation. Any other questions from afar there, or are we good to go?
There isn't, but I have one last one, and I might throw you a bit. But what is your vision? Because I know I can hear the passion throughout the presentation. And what is your ultimate vision, or what has driven you for this work that you have dedicated your life to, or these years to?
It was. I came into this field because I was working in a women's shelter in Toronto, Nellie's Hostel, the first women's shelter we had in Canada. And I noticed that a lot of the women seemed to be really stoned. And I looked on their files and I realized that a lot of them were taking this brand new drug on the market called Valium. And I had no idea what Valium was. And so I phoned up Health Canada and I said, explain to me what this is. And they said to me, well, so interesting that you're calling us because we're just putting together a kit of information that's hopefully going to raise awareness on the part of healthcare professionals about the overprescription of benzodiazepines to women and the link to violence and other concerns. And so we've got some great knowledge translation folks. We've got some great people who know a lot about prescription drug abuse in women, but we don't have anybody from the violence field yet to join up in our circle. So I started into this field taking this kit of information that we created around Ontario and around Canada. And, you know, you'll laugh now because of all the technology that we have. But it was a series of posters that you turned the next page and showed the next piece of information. And there was instead of a video clip or a YouTube clip, there was a film that required a film projector and the whole bit, right, to show the thing. So, you know, I'm really dating myself. But my vision kind of, you know, at that moment, I realized that it was really critical that we have evidence and that we have people who could translate that evidence into practice and help people make a difference in the lives of women with substance use problems. And that sort of became my little mantra. And so over time, I've been learning more and more about, you know, what the issues are, both from research and from listening to women in communities, and trying to think about what is, you know, how do we do good knowledge translation that really supports change in practice. And so I'm actually, you know, doing a doctorate at this point in virtual knowledge translation, really moving from the turn the pages over poster thing into a modern way of doing this work. So my vision really is that we keep on having things like we're having this morning, where we get a chance to talk together as service providers, as women, as researchers, as government folks, about what works and how can we bring it into being. For me, that's my vision. Thanks.
Thank you so much, Nancy, for that great presentation and the conversation that really truly happened today, much like Nancy just mentioned. It was very informative, and I think that it was inspiring to really understand where our work fits within those 4 stages and then what we might be able to do more of. And I know for myself, it's actually giving a nice framework to be able to, from the cross-ministries perspective, to be able to make sure that we are hitting the mark on all of those levels and not just putting all weight on one, because with that, then we could actually be dismantling versus helping. So very, very good. So I just wanted to note that there was the question that was being posed a few times by a few different people that there was no handouts that were accompanying the webinar today. What we're going to do is include the PowerPoint presentation as we upload it to the FASD website, and so those will be available to you once we have that opportunity to do that. Evaluations are going to be emailed to participants within the next 2 business days, so please be sure to sign the attendance sheet so that we can get these to you. It's essential, much like all of the work that we have going here in Alberta. We can only we want to do better, and we can only do better if we continually know where those areas are that we can grow to make this more of a success. Also, too, that it also meets the needs of everyone out there. I wanted to note that we had 85 sites online today that we know of, and we get a more full report tomorrow. Yeah, so 85 sites, and that might mean that there's even more individuals, given that there might be more participants at each site. So your feedback going back to the evaluation is very important to us, and we really would like to get that back here so we can infuse it within future learning series. And the other part that I want to make sure that you're aware of is please join us for our next presentation on October 24th. We have already talked, and I know Nancy mentioned it in her presentation, and I was referencing it regarding the quilting opportunity that was used for evaluation. The Alberta Parent-Child Assistance Program will be presenting on working with women who have issues with addiction. So we're going to have an opportunity to really see how that project works, what are those success points, and how do they do their work. So I just want to again say thank you everybody for your time today. Thank you, Nancy, for such a great presentation and really truly inspiring us all to further our endeavors in prevention of FASD.